And as you can see, we have a lot of targetable mutations. We have at least 8 approved targetable mutations, and these are the drugs that we currently use for these targetable mutations. And let me tell you an example, the most common, the EGFR mutation. So when a ligand attaches to the receptor, this leads to phosphorylation of the kinase domain, and this instantaneously leads to signal transduction and leads to proliferation. Now, mutation in the EGFR mutation, it ranges between 15%. However, it can be as high as 62% in the Asian population. And in Egypt, it's in the ranges of 20 to 25%. Now, the most common mutations are in exon 19 and exon 21. And when this happens, we have a over hyperactive kinase domain that is active without even ligand stimulation. And this leads to proliferation, signal transduction, and adhesion, invasion, and metastasis. So what we were able to do is that we saw that if you give EGFR target kinase, tyrosine kinase inhibitors, the first generation and the second generation, you can clearly see a response rate of 80%, 70 to 80%, compared to chemotherapy, which was 30 to 40%. Was quite impressive. Progression-free survival moved from only 5 months with chemotherapy to 13 months, and overall survival of which was beyond 2 years. Again, this was something that was a breakthrough in non-small cell lung cancer. And this really changed the roadmap for treatment of lung cancer. And now we have a third generation EGFR TKI inhibitor that could lead to a progression-free survival of almost 2 years. Progression-free survival alone of 2 years. So what we were able to do in terms of precision medicine, by just detecting the oncogenic-driven mutation, is that we could improve the progression-free survival and overall survival from just 1 year to an overall survival approaching 3 years. Actually, if you give even second-line treatment, you can go to 5 years overall survival, something that we didn't ever see before. If you remember, the survival for stage 4, 5-year overall survival was 0%. Now we have a group of patients in our country, 25% of non-small cell lung cancer patients. When they have those mutations, they are going to have a significant improvement in the overall survival. So what do we need to do? We need to be able to detect the molecular aberrations when we find them. We need to be able to monitor these aberrations. We need to be able to track resistance when it happens, because we do have drugs. We tailor our drugs based on the resistance that we see. And for the early disease, we need to be able to know if there is going to be a minimal residual disease or not, and perhaps even detect the cancer before it happens. So tissue biopsy, we only use it in terms of detecting the mutations or in tracking for resistance. And despite that, let me tell you that for mutations and biomarker detection, we can only detect 18%. It is doable in only 18% of all advanced non-small cell lung cancer patients. And this is data from the USA. And in Egypt, it's even lesser. And the problem, why is that? Because that tissue is the issue. We still don't have enough tissue to be able to do all the mutations. So how can we improve on this? I mean, liquid biopsy is basically finding circulating DNA or circulating tumor cells in the fluids, biological fluids, especially the blood. And importantly is that it is non-invasive. You can repeat it, whereas for the tissue biopsy, it's just a snapshot at a certain time. And it means that you can monitor the tumor heterogeneity. You can monitor the tumor response. It has a much faster turnaround time, which is making liquid biopsy an ideal way of detecting our mutations, which is quite important because, again, 63% of lung cancer patients will have an oncogenic driven mutation. Now, there are factors that are important for detection of the circulating tumor DNA. And by the way, we can detect a lot of things in the tumor cells, the circulating tumor cells, the exons, the RNA, but the most commonly studied was the circulating tumor DNA in non-small cell lung cancer. And it really depends on detection of the circulating tumor cells, depends on the type of tumor. Some tumors are shedders and some are not. And lung cancer, there is shedding of circulating tumor cells, circulating DNA, I mean. And the other thing is the stage of the disease. The higher the stage of the disease, the more that we are going to detect circulating tumor DNA. And the more the number of metastatic sites. So the bulk, the disease, the more the bulk of the disease, the more is the circulating tumor cells. Now, detection of the circulating tumor cells, you need to use a very sensitive technique. If you just use the PCR, the real-time PCR, you're able to detect 1 to 5% of the circulating tumor cells. But you need to go more sensitive. And this is why the digital droplet PCR is better. And more importantly, is to go for the NGS, next generation sequencing. Now, if you go for tissues, you'll be able to detect only 18 to 52% of the oncogenic driven mutations. Now, these are trials that looked at tissue and liquid biopsy. And you can see the detection of the oncogenic driven mutation is much higher when you go for liquid biopsy, approaching 95% compared to 52% in a trial, and so on in all the trials. And the concordance is quite good, almost 95% concordance between the liquid biopsy and the tissue biopsy. And turnaround time is quite short when you're doing the liquid biopsy. You're talking about days compared to weeks when we go for tissue molecular testing. So basically, we're able to save around 15 to 20% of the cases. And this is looking at, I'm sorry. And this is looking at patients in the first trial, they didn't have any tissue, and they were able to detect around 17% of their patients having oncogenic-driven mutation. In a second trial, the tissue detected 21% oncogenic-driven mutation, and they were able to detect 31% with the liquid biopsy, and so on. So you're able to save more patients by detecting the oncogenic-driven mutation in around 15 to 20%. And this way, you're able to give your correct drug to improve the survival of the patients. Now, the second important thing is to track resistance. And why is that? We know that despite the best treatments that we give, the EGFR TKI inhibitors, almost all patients are going to progress within a year and a half. And the main reason for progression in the EGFR mutant patients is T790 mutation. Now, this is present in around 60% of the cases. You need to detect it because we do have a drug, osimertinib, or a third-generation TKI inhibitor, and this drug, when you give it, you still have a response rate that is high and the progression-free survival that is again 10 months. Remember, those are patients who have a relapsed disease, and then you give them a second-line treatment. If they have the T790 mutation, survival is higher. The progression-free survival in itself is 11 months. The problem is that 20 to 50% are only tested for the T790 mutation. Again, why is that? Because we cannot take a new biopsy. We're not able to take a new biopsy. So if we're able to detect this mutation, then we are saving more patients. And this is just to show you that T790 mutation, we can detect it in around 65% of the cases if we go with NGS, and the higher the tumor burden, the more that you'll be able to detect the T790 mutation. And on the left side here, you can see that the response rate with osimertinib, if you give for the T790 mutation, is similar, is 63%, similar to that detected by the tissue. And again, post-osimertinib, we see more and more mutations, such as the MET mutations, such as PI3 kinase mutations, the HER2. Detecting the circulating DNA will be able to pick up these acquired mutations where we can treat those patients according to their mutation. And then importantly is to know how to monitor our tumors. So we know that whenever we have a tumor and there is still a circulating tumor DNA or there is a positive circulating tumor DNA, that progression-free and overall survival is significantly lower compared to those patients who don't have the circulating tumor DNA. And again, clearance of the circulating tumor DNA. So after you give the treatment, do we still have circulating tumor DNA or not? That's important to know because you can see that the survival is significantly higher when we have clearance of the circulating tumor DNA. So this is monitoring our treatment. This is something that we couldn't do with the tissue biopsy. And then what about minimal residual disease. And this, we are talking about early stage lung cancer. Those are patients who underdid surgery, they don't have a disease, and they receive their adjuvant chemotherapy. Do we need any further treatment or not? Having circulating free DNA is actually a prognostic marker, and you can see that the survival is significantly lower for those patients who have circulating tumor DNA. And this is why we're having now studies, and actually we do have in the NCI several studies looking at this. What if we have circulating tumor DNA after surgery? Do we need to escalate our treatment or not? Or do we need to de-escalate the treatment for those who don't have circulating tumor DNA? And finally, what is the status here in Egypt? We do have limitations for doing the liquid biopsy. Now, remember, in Egypt, the EGFR, I'm talking about the most common mutation, the EGFR TKI mutation, which is only 15% in Europe and in the USA. In Egypt, it represents 25% of our cases. Despite that, only 25 to 50% are tested for the mutations. And why is that? First of all, we do have doctors who don't know the importance of the testing, but more importantly is that the quantity and the quality of the tissue is poor. We cannot do the mutations for those patients, which is signifying that this is where we need to go for liquid biopsy. So do we do liquid biopsy? We actually have a lot of research on liquid biopsy. We have research for circulating tumor cells. We have research in different tumors. We do have a lot of research on circulating DNA in different tumors again. And we have exon mutations and microRNA. So these are just some of the research that we do have in Egypt. And okay. So what is hindering the use of liquid biopsy in Egypt? Why aren't we using it? The problem is that there are technical factors. So we need to know that we do have challenges in the collection and the clinical factors. Sometimes we do have a lot of false negative results. The sampling process, and I'll just elaborate a little bit because I'm a medical oncologist, I'm not a clinical pathologist, and how to analyze it. Now, the most important thing is the economical issues, because we need to have people sponsoring this test, and we need to decrease the pricing of the kits. And definitely we need personal training. So technical challenges, let me tell you that it's a 2 centimeter blood sample that we take for the patient. However, it's important to know that you should be very fast in assessing the mutation and collecting the circulating tumor DNA, because by time, what happens is that the blood cells start to lyse, and then you'll have like looking for a needle in a haystack, you'll find a lot of circulating free DNA that will really dilute the tumor-derived circulating tumor DNA, and it will be more difficult to detect. And the other thing is that with more time, there is denaturing or degradation of the circulating tumor cells, which will lead to more false negative results. And typically what we do is that okay. I don't know why it's not working. So the problem is that we need to collect this, and we need to do it fast. Typically, we need to freeze the sample when it's going to be processed, and it needs to be within 2 hours. Now the problem is that, can I have it back? Someone is moving my slides. Shall I say next? Okay. So the problem is that because of the economical challenges that we have, this is an expensive test to be done here. And what we do is we have managed to have this test sponsored. The problem is that it's sent outside it is sent outside. And by the way, we do have the NGS machines here. In Egypt, we have 30 NGS machines. The problem is that very few liquid biopsies are done in Egypt, and most of the samples are sent abroad, and the reason is because the kit is very expensive. So let me tell you that one kit is for 200,000 Egyptian pounds. So you need to have it sponsored, And you need to have the number of patients that will be able to be included in one run. The other thing is that because we're sending it abroad, and we have actually sent from the whole MENA region around 1,500 liquid biopsies. It's mainly for the EGFR, for the RAS, for the PIX3 kinases. We send a lot of liquid biopsies. But the incidence of EGFR mutation is, and again, it's in the ranges of 20%. However, the concordance with the tissue biopsy was only 70%. And the reason is it takes 4 to 6 days to travel, which means that we are going to get a lot of false negative results. And personally, it's becoming very difficult to detect EGFR mutation in an already EGFR mutant patient on liquid biopsy. So despite the fact that they are using nucleic acid stabilizing collection tubes, still we're seeing a lot of false negative results. We need to minimize the false negative results. We need to have the time of collection should be short. We need to do it in-house. It will really save a lot of time, and we need to really improve the detection of the low circulating tumor DNA, especially in low burden disease and in early disease. If we're going to be looking at early detection, we need to have very sensitive techniques to detect the very low DNA. We need to have better sampling and extractions and analysis methods. And actually, we're going to have a training next May, 18th and 19th of May. The International Liquid Biopsy Association are going to be joining forces with the ONTEC, and you're all invited for that. We need to help in building capacity and personal training. Yes, we do have the machines, but still we need to build capacity. So basically, we have changed the way we treat non-small cell lung cancer. So we've moved from a stage 4 disease with a very dismal prognosis, an overall survival of a year and a half, to now having an overall survival that is approaching 5 years, stage 4 disease, even those patients who have CNS metastasis, just by detecting the oncogenic-driven mutation. And we have 8 approved mutations with drug